You can hear me. Just give me a thumbs up, Dr. Snyder, if you can hear me. Okay, good. Thank you Dr. Snyder for allowing me to talk today. I look forward to talking about my favorite topic, which is the ear. I don't know if that's a scary thing, but I'm excited to talk about it. I'll be very quick. Just this is an introductory slide to introduce you to our practice. If you don't know us already, I'm sure we've interacted with many of you in the past. But on the top left, you see Dr. Glicksman, me, Johanna Lamb, our nurse practitioner, Peg Toro, and Ricole Hayden. Really very excited to have this amazing team, and we're all excited to take care of yours and our patients. Just quickly, there's the bolded phone number is for staff, an MD line. It'll call directly into our office, and you have our cell phone numbers listed. Please call us anytime with questions, concerns. We're always here for you. Let's see here. All right, so today we're talking about ear fullness. I thought I'd bring in the Karate Kid because everyone knows Daniel-san, and there's more than one reason for ear fullness. Mr. Miyagi taught Daniel-san that you should trust the quality of what you know, not the quantity. So, patient comes in, says, "Doc, my tube's not working." That usually brings 4 or so quick things to most providers' minds. Is there fluid in the middle ear? Were they flying? Is it wax? Did they put a Q-tip in their ear, and is there a cotton in there? Those are the common things that a lot of people think about. But what I want to do today is try and drill into everyone's mind all the other possible things that might be going on, and some of the more concerning ones that we should always think about. So let's expand our differential. I'm going to introduce 4 cases. I'm not going to go into the results until the end of the talk, but I want you to think throughout the talk as we review differential of ear fullness, what they might have. So this first patient was a 22-year-old, presented with left ear fullness, otherwise totally healthy. His audiogram was normal, his tympanogram was normal, his word recognition scores were normal, his pneumatic otoscopy was normal, his tuning forks were normal. We spoke about the possibilities, and I said, why don't you come back in 6 months? We'll repeat a hearing test. We'll try and drill down the differential, see if anything has changed. I'm going to take this opportunity to spend 2 minutes or maybe 1 minute just looking and reminding everyone how to interpret an audiogram. You see 125 here. The x-axis is the frequency that we're testing the ear at. 250 hertz is the low frequency, 8 kilohertz is the high frequency. These are normalized sound pressure levels, dBHL. Starting at 0 to 20 is the normal range. The louder we need to make the sound in order for you to hear it, the lower you go down on the graph. So between 0 and 20 is the normal range. The little brackets are the tests that we do when we test directly the inner ear. We bypass the external ear, eardrum, and middle ear by placing a bone probe on the mastoid or on the forehead. That's Dr. Hayden and Dr. Toro's job. They will test the inner ear directly with a bone conduction device. And that's what those brackets are. Red is right, blue is left. If the circles is the right, X's is the left. If they are significantly below those brackets, that means there is a hearing loss somewhere within the ear canal, eardrum, or middle ear. If both the brackets and the circles and X's are reduced, that means it's a sensory neural or nerve-related hearing loss. Here you have a tympanogram. Normal tympanograms look like this with a peak somewhere in the box. We're going to move on from this. Case number 2 is a 69-year-old male who presented with bilateral, slowly progressive hearing loss, fullness in the ears. He had a normal pneumatic otoscopy. His Weber lateralized to the left ear, which you can see is the worst hearing ear. Here we have the X's are 60 to 80 dB hearing loss. That's in the severe hearing loss range. And with the brackets, we see those little brackets are pretty much significantly higher up. So what that means is that his nerve hearing is much better than his overall hearing, which means that there is a decrease in sound somewhere along the ear canal, eardrum, or middle ear axis. So we'll come back to this patient. Here's another patient who had recurrent sinusitis history, ear infection history, came in with a diagnosis of chronic eustachian tube dysfunction and on and off right-sided ear fullness and crackling sounds. It was really bothersome to him. His ear exam was beautiful. Normal eardrum, normal middle ear. He had slight negative pressure in the middle ear, but a normal nasopharyngoscopy. We'll come back to this patient as well. And the last one is a 43-year-old female who presented with left-sided ear fullness, intermittent ear pain, waking her up at night sometimes, muffled feeling in the ear, but a normal ear exam. So what I want to do is talk about a differential for ear problems. And you'll see what's interesting is that we always think about the ear. That's obviously a common problem when someone comes in with an ear problem. But many times, in fact, I would almost venture to say often, or almost 50% of the time, the problem is not the ear. So we always have to branch out, make the first branch in our differential and list the ear-related issues and the not ear-related issues that might be the problem. So the most important thing when it comes, I think, to figuring out issues with ear and muffled ear feelings is a guided history. And I tend to, the organization that I use is I go from out to in. So I tend to think about the external ear first, the ear, the pinna, the ear canal. Then we get to the eardrum and the middle ear. Then we extend into the inner ear or the cochlea. And then from the cochlea out the nerve into the internal auditory canal and then the brain. I wanted to look at these two pictures in the middle and bottom of your screen, just because it's a nice representation of all the complex anatomy that's surrounding the ear, okay? We think about the middle ear as a box, and in that box, you have 6 sides. One side is the eardrum, the other side is the floor of the middle ear. So right here's the eardrum, the floor of the middle ear. You have anterior, posterior, superior, and inferior. Superiorly, you have the epitympanum right over here, and above that is the middle cranial fossa. Inferiorly, you have the jugular vein riding up right over here, okay? Along the floor, this is, it's a 3D, so it's not exactly just the floor, but here you have the facial nerve running through the middle ear. Anteriorly is the opening of the eustachian tube running to the nasopharynx. And then posteriorly, mastoid, the opening into the mastoid, and posteriorly within the mastoid, the posterior fossa dura. A lot of really important structures, right? Carotid artery, facial nerve, chorda tympani, jugular, and mastoid, middle cranial fossa. And of course, the cochlear promontory here, which is the basal turn of the cochlea. And if you look real carefully, and I'm happy to show anyone who's interested, you come to my office, I can show you that you can see some of these things with standard otoscopy. You also have to guide your history, thinking about other things that cause ear fullness, including cervical spine issues, sinus and dental issues, temporalis. You ask about pain, worse in the morning. You ask about headaches and migraine, neuropathy. All these different questions that you can think about as the patient presents. So let's go through the differential. It's already 12:40, so I'll try and not go too fast, but it's a really long differential when you're talking about ear problems and ear fullness. It's really important to at least expand one's mind a little bit when first presented with a patient so that you don't miss some of the more important things. So obviously cerumen form body, we're past that, okay? That was the wax on part, now we're gonna go to the wax off part. Infectious causes are very common, otitis externa, cellulitis, those are common causes of ear fullness and pain. Always important to think about zoster oticus. That it's pretty rare, but you'll see you can sometimes see a rash in the ear, and ear pain and fullness, hearing loss, facial nerve weakness. That's an uncommon but important thing to know about. Trauma of the ear canal, relapsing polychondritis of the cartilage. There are neoplasms that involve the external ear, squamous cell carcinoma, benign neoplasm like a ceruminoma, and then canal stenosis. All of these can cause external ear causes of ear fullness or ear pain. Next, we're going to go down towards the medially towards the brain, and now we're going to talk about the eardrum. Eardrum causes problems too, and often people kind of think lateral to the eardrum, which is the ear canal, or medial to the eardrum, which is the middle ear, but sometimes the eardrum is ignored. We don't want to ignore the eardrum. You can have perforations of the eardrum, acute or chronic. You can have myringitis, inflammation of the eardrum, infectious, inflammatory postoperative is a common cause of myringitis. You can have epithelial crusts that occur after an otitis media, and of course a neoplasm, a cyst within the drum itself. The pictures that you see on top is a normal eardrum, and then inferiorly you see a large tympanic membrane perforation. You can actually see here, I'll show you, this is stapes right over here. This is a right ear. The stapes is attached through some sort of fibrous connection here to an eroded incus. This is your malleus here, and they connect up here in the epitympanum, comes back down this way. The oval window is right here. You can see the facial nerve running right above here. And then this is the round window here. This is the cochlear promontory right over here. It's amazing how much anatomy you can actually see through either a perforation or a translucent tympanic membrane. This is an opposite ear. This is a left-sided ear. Here you can see the malleus. Here you can see the incus coming down. This is the cochlear promontory here, and the round window right over there, okay? Eustachian tube is right over here, that little shadow, that's where the eustachian tube opens up into the middle ear. All right, so let's go on to the middle ear differential. Ear fullness you can have from hearing loss that's conductive in nature. That can happen from an infection or a serous otitis media. You can have a cholesteatoma, acquired or congenital cholesteatoma of the middle ear. Branchial cleft is unlikely, I will go past that. A siccular discontinuity, that's the ossicles or the ear bones here, a siccular discontinuity from trauma, recurrent infections. You can have attenuation of the transmission of sound through those ossicles from an external source, like an encephalocele just touching the ossicular chain that's coming through what's called the tegmen, or the separation between the middle cranial fossa and the ear. And of course, neoplasms of the middle ear can cause hearing loss and ear fullness, okay? Let's get to the inner ear. Usually this is a sensory neural, so the ear fullness that someone experiences is a sensory neural hearing loss, and that can happen from noise exposure, an idiopathic sudden sensory neural hearing loss, which is one of our common ear emergencies. I'm gonna stick with this for 30 seconds, and this can, the common history is I woke up with hearing loss, I have ringing in my ear, I might feel a little bit off balance, and it feels different than I would expect from just plugging up my ear. They really, the history is usually a little bit different, but this is an important diagnosis that's not to miss if possible. We'd like to see patients urgently in the office within a couple of days, and if we can't, we start them empirically on prednisone. One way to differentiate between a sudden conductive hearing loss like earwax and this, assuming that the other ear is normal, if you have the patient hum like this, and they hear it in the bad ear, that's suggestive of a conductive hearing loss rather than a sudden sensory neural hearing loss. Of course, looking in the ear, if you have a normal ear exam, don't assume it's a fluid, do a tuning fork exam, and that can help you differentiate between a conductive serous otitis media or other conductive cause of hearing loss versus a sudden idiopathic sensory neural hearing loss. Meniere's disease, labyrinthitis, zoster we spoke about, and medication side effects, such as chemotherapy, can all cause hearing loss. Other inner ear problems, such as superior semicircular canal dehiscence, and what that is that the superior semicircular canal, which is attached to the cochlea, all the canals are attached to the cochlea via the fluid. The top part of it can sometimes be dehiscent into the middle cranial fossa, and that can cause ear fullness, autophony, where patients sometimes hear themselves talking. They can sometimes hear themselves walking in their ear or moving their eyes. It's a very strange syndrome. They can sometimes hear that in their ear as well. Temporal bone fracture is not an outpatient issue. Severe head trauma, patients are usually intubated, so that's not going to be your common patient. Enlarged vestibular aqueduct is a congenital abnormality where the connection between the inner ear and the brain is enlarged, and that can cause hearing loss over time. So I have about 7 minutes or so, so I'm going to go a little bit faster through this here. The differential for not an ear problem, and by far the most common thing we see is temporomandibular joint disorder. People can have just ear fullness, and if you explore, sometimes you'll get other symptoms like pain, worse in the morning, worse after meals, but that's something that's very high on the list. Dental disease, a cavity a root infection can be very minor, and I've seen patients who present weeks after their initial ear fullness presentation to the dentist. They get their tooth fixed, pulled, whatever happens, their ear fullness goes away. Referred cervical spine disorder, a skull-based neoplasm, cranial neuropathies, and much less likely a referred pharyngeal source. We worry more about pain in the ear. If you can't figure it out, we always look at the back of the throat to make sure there's no neoplasm causing referred ear pain. All right, so let's go back to our cases because we're going to run out of time soon. The first case was that 22-year-old with ear fullness. That's all he had, ear fullness. Maybe it was TMJ, right? It was normal exam. Maybe that's the first thing that would come to mind. He didn't have any tenderness. Maybe it was a little crust on the eardrum, but I didn't see that. There was no negative pressure. Maybe it was a slight tiny hearing loss that we couldn't detect. So that's why we had him follow up, because we also thought, well, it could be a retrocochlear etiology, something in the inner ear or internal auditory canal. And what was it? We'll tell you in a second. He presented 6 months for his follow-up with severe sensory neural hearing loss. He couldn't understand anything out of his left ear, and he didn't tell us when it happened. He came in, it had happened 2 months before his follow-up, but he just said, okay, I have the doctor's appointment in 2 months, I'll come in then. So immediately we ordered an MRI, and right over here, this is the left internal auditory canal. This is the cochlea right over here. These are the semicircular canals in the vestibule. And here you see a mass filling the internal auditory canal as well as the CP angle and pushing on the brainstem. So that was a bad one. This is not a common presentation, but we always had the reason we had him follow up is because it was on our differential. Ear fullness, unexplained, we had follow up. You could have argued, I could have ordered the MRI right from the beginning, but then I'd probably be ordering 10 MRIs a day. So let's talk about the next patient. Just by the way, this patient had, I don't do neurosurgery, but this patient had surgery, and he had severe cerebellar edema requiring a partial cerebellar resection, and they couldn't take out the tumor, and he still has that in his head. At some point, he'll probably have to have that removed. So next patient had the mixed hearing loss. That means both sensory neural and conductive hearing loss, worse in the left ear. He had normal pneumatic otoscopy. He had normal tympanometry. And so why did he have the conductive hearing loss? And based on his presentation, the most likely cause was what's called otosclerosis, which is a bone turnover abnormality of the otic capsule, including the oval window, and you can get a conductive hearing loss. And what you do is you take out, this is the ossicular chain here. This is where the bone, this is like a piston, right? That goes in and out of the inner ear. Right over here, the bone can get stuck. It's like a fused. And so what you do is you bypass the bone. You can remove this little bone here. It's called a stapedectomy. And this is a picture here after the bone was removed. And there's a little prosthesis that extends down, and I make a little hole opening into the vestibule. And now this piston can bypass the pathology and transmit sound into the inner ear. This is a very elegant surgery, just because for us, we love this because we can take someone who has very poor hearing and give them good hearing. So now on the right side of the screen here, you see his air conduction thresholds were between 60 and 80. And post-operatively in the left ear, he came up to 20 here in the low frequencies and down in the high frequencies. But we basically closed his air bone gap post-operatively. And his only complaint was that everything was too loud. And I told him, I'm sorry, I couldn't fix that. Just to give you an idea of the size of these bones, here's the stapes. It's pretty tiny, right? And this prosthesis here is 0.5 millimeters in diameter and extends from here to the depth 4.75 millimeters. It's pretty darn small. Next patient, 62-year-old, presented with history of eustachian tube dysfunction, normal exam, normal audiogram except for slight negative pressure. I ordered a CT scan of the sinuses because his history was a little bit strange. I really did not think he had eustachian tube dysfunction. I thought he could have chronic sinusitis or maybe a mucocele or something else that might be causing his symptoms. So I ordered a CT scan of the sinuses. However, what we found was an encephalocele. If you look over here, right over here, this is a coronal CT scan through the level of the cochlea. Here's the facial nerve right over here. And then here, we're missing bone. And there's this little gray stuff touching the malleus. That's the head of the malleus right there. It's supposed to look like this, okay? Not like this. And here, in retrospect, we look back at an MRI he'd had for another problem, and you can actually see right in the middle here, this white spot, that's a fluid intensity, right? It's a T2 MRI, right in the epitympanum where the encephalocele is sitting. So that was the cause, and he needed a middle cranial fossa approach for a repair. All right, last case, but the most common is a 45-year-old with left ear fullness, intermittent left ear pain, waking her up at night. And her left ear, her main complaint, to be honest, was that she had muffled hearing. She had a totally normal ear exam, normal neck exam, normal pharyngoscopy, and she had no evidence of sinusitis. And when we palpated her temporomandibular joint, it was very tender. You can also have tenderness over the temporalis or the masseter muscles that are depicted in the picture on the right. And the treatment is, we start with conservative therapy. The common things we do is Motrin 600 TID for a week or two, a mouth guard at night, soft diet, warm compresses, jaw stretches, simple stuff. And usually we get a significant improvement in symptoms, and it helps us make the diagnosis. If they feel a lot better, we start to convince them that this is the problem. I often know the diagnosis when the patient starts telling me their history. They tell me that it hurts in the morning. When they wake up, they sometimes wake up at night with pain, sharp stabbing pains, worse after eating. So before I examine them, I say to them, I think your ear is going to look normal. Because if I don't say that, when I tell them that I think it's the temporomandibular joint, they tend not to believe me. So, that's my trick. Johanna, our wonderful nurse practitioner, has introduced Botox injections into the masseter and temporalis for patients with severe symptoms, and that has helped them significantly. So, just to finish off, I want you to have this picture in your mind of Daniel-san kicking this guy in the face every time you think about ear fullness. And to think about the wax off, not wax on possible causes for ear fullness. And I'm happy to take any questions. Again, this is our amazing staff. And our phone number in bold is a backline MD only phone number. And our cell phones are here for you to always call us with questions or concerns. I'm happy to take questions.
Thank you so much. I really appreciate you giving us this talk. I don't see any questions in the chat box. We do have a couple of minutes if people want to chime in or jump in. I will ask a question. Maybe I can fill the last 3 minutes with a question that I think all of us have, which has nothing to do with the ear. But you want to give us 3 minutes on why the coronavirus takes away people's smell? Or what our patients can do after they recover from coronavirus and they still can't smell or taste anything.
Oh, goodness. All right. So let's just talk about viral anosmia, right? Because that's what's happening. And that's one of the most frustrating patient complaints when they had a cold. Doc, I had a cold. I lost my sense of smell during the cold, but it never came back. And that's not new to coronavirus, COVID, SARS-CoV-2, right? It's something that we've had forever, but it's just come into in the forefront of the news because of coronavirus, which has been around before and causing anosmia, just not killing as many people, which is obviously very unfortunate. So you get basically a post-viral neuropathy of the. I'm assuming that this virus is causing the same type of post-viral neuropathy that you see with other upper respiratory tract infections. And what we reassure patients that we tell them that there's nothing else we can do in terms of a workup, reassure them that it's not a tumor or anything scary like that. And if they have no sense of smell or very little sense of smell, we'll recommend smell retraining therapy, which is basically you take 4 different smells, rose and other ones, and you smell them a couple of times a day. And there's evidence to show that working on that smelling gets those neurons working again and reconnecting. You get some improvement. I don't know if there's any evidence yet for coronavirus, specifically COVID-19, but certainly in other anosmia cases that it can be helpful.
That's really interesting. Yeah. So there has been some written about that. So we can definitely advise our patients to go ahead and start doing something like that. That's great.
Yeah.
All right. Well, thanks very much for taking the time to do the talk. I hope everyone has a nice weekend. Something I thought I would never say. Enjoy, NFL playoff football. I can't believe we made it through the whole season, but we did. So there's the crown jewel, the NFL playoffs. Hope everyone enjoys that. We'll see you all next Thursday for a great talk about elbow pain. Thank you, Dr. Alifas.
Thank you.